warm welcome to all the delegates and all the faculties and the students for today's case presentation of ISCCM ICU Clinic. And I welcome Dr. Ranveer Singh Tyagi sir, who is the uh, person behind this ISCCM ICU clinic, and the main purpose of this is to mentor the students, IDCCM and DRNB students, for exam going, to have them the exact platform to present cases like real exam scenario, so that they are well prepared for the exam. And the examiners are the examiners of IDCCM and DRNB, so they will have a just practical feeling of giving practical exam. So for the third year exam going students, this is the best platform. So my heartfelt thanks to Dr. Ranveer Singh Tyagi sir for having this idea from ISCCM platform for the students throughout India. So I welcome you, sir, to this platform.
Thank you.
For today's evening, we have our examiners, Dr. Prakash Sastry sir and Dr. Pradeep Rangappa sir. Dr. Prakash Sastry sir is the chairman, Institute of Critical Care Medicine, Sar Gangaram Hospital. And I'm happy that he did his MBBS from Sambalpur University from Odisha, and did his MD in anesthesia at HCV Medical College, Cuttack from Odisha. And sir then did his SRship at AIMS and Safdarjung. Then he was consultant anesthesiologist at Yorkshire Hospital and Wales Hospital. And he was a research fellow at St. James University at Leeds. And he has multiple publications and book chapters. He's a speaker, teacher, guide, and mentor to a lot of students throughout India. And I think he's the best person for fungal infection, one of the pioneer persons of fungal infections in ICU, as a teacher, as a speaker in India. So I welcome you, sir, for today's academic meet. Prakash Sastry, sir.
Thank you. Thank you very much.
Thank you, sir. And I welcome Dr. Pradeep Rangappa, sir, who is the head of the department and director of critical care medicine, Manipal Hospital, Bangalore. And he is the ISCCM President-elect 2026 and 27. He was the ISCCM Vice President 2020 to 22. He was the past Secretary ISCCM Bangalore Chapter. He was the organizing secretary of Critica 2015, GAPIO 2016, GICS everybody knows 2022, past accreditation secretary of ISCCM, and he has done his fellowship of joint faculty of intensive care medicine in Australia, and he has done FCICM fellow of intensive care medicine Australia, and he has multiple publications and book chapters and international publications, and he's a guide, teacher, mentor, and moreover he has more than 500 YouTube videos on critical care medicine, exactly speaking around 525 or 526, sir, around 525 YouTube videos, I think.
Yeah.
So he's a well-known teacher, guide, and mentor for all the students throughout India. Sir, I welcome you to today's academic meet, sir.
Thank you, Anand bhai. Thank you so much.
Welcome, sir. And then I would like to welcome Dr. Tejas Karmata, who is the clinical director and senior consultant at Gokul Hospital, Rajkot. And he is the zonal representative of ISCCM West Zone, National ISCCM. And he's a teacher and guide for IDCCM and DRNB students. And for today's evening, he's the mentor of both the students for case presentation for today's evening. So I welcome Dr. Tejas for today's academic meet.
Yeah, good evening, everybody, and welcome.
Thank you, sir. And now I would like to introduce our both the students, Dr. Abdul Said, who is a IDCCM student at Gokul Hospital, Rajkot, and he will be presenting the first case on mucormycosis. And our second student is Dr. Vikas Reddy, who is a first year DRNB student at Yashoda Hospital, Hyderabad, who will be presenting the second case on candidemia. And along with me is Dr. Bhavani Prasad, who is the clinical director of critical care medicine and head of the department, Care Hospital, Banjara Hills and High Tech City, who was the past chairman of Hyderabad chapter. So, Dr. Bhavani, I welcome you and I think both of us will coordinate the session. And without further delay, the sequence of events will be: first case will be presented by Dr. Abdul, mucormycosis, for 15 minutes. Then the second case presentation on candidemia by Dr. Bikas for next 15 minutes. Then it will be open for question and answer session by both the examiners, Prakash Sastry sir and Pradeep Rangappa sir, to both the students. And then any question by the delegates, they can put their questions in the chat box. So after the question answer session, those questions and overall fungal infections will be discussed in the same platform. So without further delay, sir, should we start the first case presentation?
Please do.
Yes,
Please
So I
do.
request, yeah, Dr. Abdul, I request you to to present your first case.
Yes, sir. Yes, sir.
Yeah, thank you. Thank you.
Thank you, sir. Welcome all, respected teachers. Today I'm going to present the case on fungal infection in ICU, mucormycosis, under the mentorship of Dr. Tejas Karamta, sir, consultant intensivist and director at Gokul Super Speciality Hospital, Rajkot. Presenting a case of 54-year-old female, weighing 60 kg. She's from Tankara, district Rajkot, and she's housewife. Patient was initially admitted at Civil Hospital Rajkot from 21st of May 2025 to 29th of June with history of pain on left side of face and decreased vision in left eye. Patient was first time detected diabetes mellitus type 2 over there. Following that, MRI, PNS and orbit was done, suggestive of invasive fungal infection in left maxillary sinus, left ethmoidal sinus, left nasal turbinate and left orbit. Nasal endoscopy was done, suggestive of left side blackish crusting and mucopus. Her surgery was done on 22nd of May 2025 and tissues were sent for histopathological examination, later on suggestive of mucormycosis sinusitis. On 30th of May, patient developed right side upper limb and lower limb weakness. Following that, MRI brain was done, suggestive of left thalamocapsular region acute infarct and few scattered hyperintensities in left cortical and subcortical area, suggestive of acute infarct likely. She was treated with conventional amphotericin B 50 mg in 500 ml of normal saline, followed by 500 ml of normal saline, and total 28 doses were given. She was treated also with injection ceftriaxone, injection metronidazole. Her sugar was controlled with regular insulin and tablet aspirin, atorvastatin, and rest of the supportive treatments were provided. Patient came to Gokul Hospital on 30th of June 2025 with complaint of generalized weakness and altered sensorium for last 3 to 4 days. On examination, her vitals were normal except her blood pressure 152/90. In systemic examination, respiratory system and cardiovascular system were normal. On CNS examination, she was drowsy but arousable and GC scale was E3, V2, M5. She had right-sided weakness. On left side, spontaneous movements were there. Right side, pupil was 5 mm dilated and not reacting to light. And on left eye, it was muddy and vision assessment was not possible as patient was not oriented. Patient shifted to ICU after initial assessment and primary treatment and related blood investigation were sent. Her hemoglobin was 8.2. Total WBC were 12,420. Her C-reactive protein was 32.5 and her creatinine, platelets, eosinophil and random blood sugar were normal. Her electrolytes were normal except there was severe hypokalemia. Her echocardiography was normal, ejection fraction 60% with mild aortic regurgitation. Lumbar puncture was done and CSF was sent for culture sensitivity and gene expert study which were negative. CSF lactate was raised, CSF routine micro, glucose, protein, and total WBCs were raised, and her random plasma glucose was 218. Gram stain and Zimsa stain were negative. She was treated with liposomal amphotericin B, 300 mg in 500 ml of normal saline with 5% dextrose over 3 to 4 hours. Tablet osaconazole was given. On first day, 300 mg twice a day, then 300 mg once a day. Injection cefoperazone sulbactam was started. Her sugar was controlled with human ectrapid, regular insulin, with symptomatic and supportive treatment. And right internal jugular vein cannulation was done, and potassium replacement was initiated. On 1st of July, MRI brain, orbit, and paranasal sinuses with MR angiography was done, suggestive of mucosal thickening and non-enhancing soft tissue components involving bilateral maxillary and ethmoidal sinus, left greater than right, and left frontoethmoidal recess extension, suggestive of angioinvasive disease mucormycosis likely. There was also secondary infiltration of left orbital apex and left cavernous sinus region. There was also secondary optic neuritis on left side and recent onset non-hemorrhagic infarction involving cortical gray and subcortical white matter of left temporal and occipital lobe, along with left optic tract, left thalamocapsular region without significant mass defect. There was also partial occlusion of left carotid artery. Neurophysician opinion was sought after assessing CSF study and MRI. Guarded prognosis were explained to the relative in detail. ENT reference was done. Advice endoscopic surgery and debridement with biopsy under general anesthesia and advice to continue antifungals. Ophthalmology reference was done. On examination, left eye anterior chamber showed total hyphena, so detailed examination was not possible. And advice left eye exenteration and less chances of vision improvement were explained. On 2nd of July, functional endoscopic sinus surgery was done jointly by ENT surgeon and ophthalmic surgeon with debridement, biopsy, and left eye exenteration, and tissues were sent for histopathological examination, suggestive of fungal infection likely to be mucormycosis on 8th of July. KOH10 and TB PCR were negative. First culture sensitivity sent and suggestive of Pseudomonas aeruginosa. Her sodium potassium was 2.13. Platelet and INR were normal. Postoperative mechanical ventilation was continued with controlled mandatory ventilation mode. Rice tube feeding started and tablet aspirin stopped. On 3rd of July, injection cefoperazone sulbactam stopped and injection meropenem started, and also tablet linezolid was added. In view of hypotension, after initial fluid challenge, injection noradrenaline was started, and as her sodium was 153, she was treated with 0.45% NS and 5% dextrose till 5th of July, till sodium was 143. Her albumin was on lower side, CRP was 62.7, and DVT pump was added to the treatment. On 4th of July, there was an episode of melena, and her platelet decreased. Tablet linezolid was stopped. Injection noradrenaline continued, and CRP was raised. Ventilation was continued with sedation, and injection pantoprazole infusion was started. On 5th of July, again there was melena with fever. Her HB dropped to 8.2 gram. So 2 leukoreduced red cell concentrate were infused. Injection noradrenaline continued, and her platelet decreased 84,000. CRP was 97.3, and ventilation was continued with sedation. Tracheostomy was done on the same day with 7 mm cuff tube. Her creatinine, INR, and APTTs were normal. On 6th of July, there was fever and ventilation continued. Injection meropenem stopped in view of there was a post culture sensitivity report was arrived suggestive of gram-negative bacilli pseudomonas. So injection ceftazidime avibactam and injection aztreonam were started. In the evening, patient suffered pulseless ventricular tachycardia. So 2 cycles of CPR were given with 2 shocks and patient reverted. These are the patient's culture report, culture and sensitivity. Her ABG after ventricular tachycardia. Injection amiodarone 150 milligram was given and later on continued with infusion. Her sodium was normal, sodium chloride, but potassium there was hyperkalemia and hypocalcemia. Magnesium and phosphorus were normal. Injection calcium gluconate and sodium bicarbonate 100 milligram intravenous state was given, followed by bicarbonate infusion and GI drip. Blood was sent for culture and sensitivity, which was negative on 8th of July. On 7th of July, we started weaning. Patient shifted on pressure support ventilation mode with FiO to 40%, support of 14, PEEP 5, and her platelet was still low, 74,000. Injection calcium gluconate was continued. On 9th of July, patient gradually started improving from thrombocytopenia and her platelets were 1,03,000. CRP came down to 37.2 and injection noradrenaline was stopped. Patient shifted on TPs and tablet aspirin restarted. On 11th of July, patient was on TPs only and there was a spike of fever. On 12th of July, patient became afebrile with antifungal and antibiotics. Right interjugular central line was removed and subclavian venous catheterization was done on right side and patient shifted to ward in the evening. Blood was sent for culture and sensitivity, which came negative on 14th of July, and her GCS was E3 VT M5. On 18th of July, we completed the 14 days of antibiotic and injection amphotericin B. Patient sensorium improved, started following simple commands. Subclavian central line was removed and rice tube was kept and patient was discharged after collaborating with other specialties with tablet posaconazole, injection human mixtard, statins, aspirin and high protein diet with other supportive measures. The final diagnosis is rhino-orbital cerebral mucormycosis with acute ischemic infarcts with septicemic shock in known case of diabetes mellitus type 2. Thank you very much.
Thank you, Dr. Abdul. It was a excellent case presentation, and the final outcome was good. We'll take up the questions. Yeah, we'll take up the questions at the end. So thank you. And now I invite Dr. Vikas to present the second case. Dr. Vikas?
I think Dr.
Yes, sir.
Abdul,
Yes, sir. Yes, sir. I'm trying to share my PPT on.
Dr. Abdul should stop staring.
Good evening to all the esteemed examiners. And I'm myself, Dr. Vikas. I'm a first-year DRMB resident from Yashoda Hospitals. And today I'm going to present a case of invasive fungal infections in our ICU. So coming to the case details, she's a 36-year-old elderly multigravid. It's a case of severe preeclampsia. With 23 weeks of gestation, underwent emergency hysterotomy, and patient had seizures postoperatively with increased abdominal drain output. So with these complaints of postoperative seizures and increased abdominal drain output, the patient presented to our ER for further management. Coming to the history of presenting illness, patient was apparently normal, having regular antenatal checkups until 6 months of amenorrhea, when she developed a sudden onset of diffuse headache associated with blurring of vision and dizziness. She initially visited a local hospital with the above complaints and was found to have a BP of 200 by 110 millimeters of mercury. She was initially given injection labetalol 20 milligrams IV stat, and in view of severe preeclampsia, she was taken up for emergency hysterotomy. Post-surgery, the patient had one episode of generalized tonic-clonic seizures, for which she received injection magnesium sulfate 4 gram IV stat and was referred here in view of seizures and increased abdominal drain output. Coming to the past history, she's not a known case of hypertension, diabetes, thyroid disorders, epilepsy, or tuberculosis. Personal history: she's a vegetarian by diet. Appetite is normal. Bowel and bladder habits are normal. She has an adequate sleep, and there is no significant history suggestive of drug or substance abuse. Obstetric history: the first pregnancy, it is a full-term pregnancy. The male baby is delivered by LSCS. Birth weight of the baby is 1.5 kgs, but the baby died at 2 years of age due to congenital heart disease. In the second pregnancy, it is a missed abortion at 3 months of amenorrhea. And in the third pregnancy, it is an IVF conception, which is a present pregnancy, and the patient, in view of severe preeclampsia, has underwent a hysterotomy at 6 months of amenorrhea. So this is how the patient has presented to our emergency department with the following vitals. On arrival to the ER, the patient was drowsy with a GCS of E2, V3, M4, a total score of 9 by 15, with bilateral pupils 2 mm reacting to light. In view of the poor GCS and respiratory distress, the airway was found to be threatened, with the breathing of saturations of 95% on 6 liters of oxygen via face mask, with a respiratory rate of 35 cycles per minute. Coming to circulation, the patient was found to be hypotensive on presentation with a BP of 90 by 70 millimeters of mercury, with a tachycardia of heart rate 124 beats per minute, which was regular, a low volume pulse with cool peripheries, and a delayed capillary refill time of more than 4 seconds. And the abdominal drain with which she presented contained 450 ml of sanguineous collection. ABG was done on arrival, which showed a pH of 7.2, a PCO2 of 14, a PO2 of 112 on 6 liters of oxygen via face mask, a bicarb of 9.1, lactates of 12 millimoles per liter, with a corrected anion gap of 29, and PF ratios of 186, and an expected PaCO2 according to the Winter's formula of 19.5 to 23.5. But here the patient was having a PCO2 of 14, indicating that she was hyperventilating, with a delta ratio of 0.9, suggestive of anion gap metabolic acidosis with lactic acidosis and respiratory alkalosis. So this was the ABG of the patient on arrival. Coming to the course in the hospital, in view of severe high non-cap metabolic acidosis and poor GCS, the patient was intubated in the ER and was mechanically ventilated. So these are the ventilatory settings. She was controlled. She was on controlled mandatory ventilation with a FiO2 of 80%, which was further reduced to 60% based on the ABG values, with a PEEP of 6 centimeters of water, with a respiratory rate of 26 cycles per minute, and a tidal volume of 400 ml. So initially in the ER, blood cultures were sent, and patient was started on broad spectrum antibiotics, injection piperacillin tazobactam 4.5 grams 12th hourly, and injection metronidazole 500 mg 8th hourly. Patient was then shifted to the ICU, where invasive lines were secured, that is the right IJV central venous catheter, and left radial arterial lines were secured. With a provisional working diagnosis of pregnancy-induced hypertension with postpartum eclampsia, status post-emergency hysterotomy with HELP patient in HELP syndrome and DIC, multiple blood products were transfused in view of ongoing consumption coagulopathy. Around a total of 6 FFPs, 3 RDPs, 1 PRBC, and 10 cooled cryos were transfused to the patient. Post this volume resuscitation, patient's BP has improved with a decreasing drain output. And the patient was also started on injection magnesium sulfate 1 gram per hour for 24 hours. These are the investigations of the patient on arrival, showing a hemoglobin of 7.1 and a PCO of 19.2, a total count of 18,500 with the platelets of 26,000, indicating the patient was in anemia with elevated TLCs, and there was thrombocytopenia. And the LF2 was showing an elevated total bilirubin of 7.2 with severe transaminitis in the form of SGOT and SGPT of 1539 and 559, elevated liver enzymes. And the fibrinogen initial presentation was 40, and post resuscitation, with the fibrosity was improved to 395 and later to 456. And the LDH of the patient on presentation was 6,675. So on arrival, the other investigations, the RFT was showing a blood urea of 50 milligram per deciliter with a serum creat of 2.2 milligram per deciliter, and the electrolytes were normal. And the patient was having coagulopathy with an INR of 5.8. The rest investigations, serum calcium of 7.5 and corrected calcium was around 8.3. So these were the initial investigations that the patient is presented with. And later we have subjected the patient for a CECT abdomen. And the CECT abdomen has shown a hepatomegaly with heterogeneous fatty changes, which was suggestive of a liver parenchymal disease, with an edematous gallbladder and a bulky uterus with post-hysterotomy changes, and a few filling defects in the left lobe of pulmonary artery branches, likely suggestive of a pulmonary thromboembolism. CT brain was done, which showed a settled subcortical white matter hypodensities, which were seen in the bilateral occipital regions, likely suggestive of a posterior reversible encephalopathy syndrome. And 2D echo was done, which showed a good LV by RV function with an EF of 66%, but there was no regional wall motion abnormality, and patient had a mild PAH. And chest X-ray was showing a normal lung parenchyma bilaterally. So coming to the course of the patient in our hospital, if in the initial 1 to 4 days, in view of the ongoing oliguric AK with severe metabolic acidosis, a total of 3 sessions of SLED were done through the right femoral hemodialysis catheter. Mechanical ventilation was continued and blood products were transfused to correct the DAC and anemia. And in view of persistent hypoglycemia, patient was started on 25% dextrose infusion, and drain output started to reduce, and the overall general condition of the patient improved, and the patient was extubated on day 4 onto an IV. Coming from day 4 to day 8, the supportive measures were continued, and the patient was shifted out of the ICU on day 8. However, the patient started to have a new onset fever in the ward when 2 sets of blood cultures were sent immediately, and invasive line, one from the invasive line and one from the peripheral line, and antibiotics were escalated to injection meropenem, and invasive lines were changed. Urine was sent for culture sensitivity. On day 10, the blood culture showed a positive growth for yeast, and thus the patient was started on injection anadrolfungin, 200 milligrams stat followed by 100 milligrams IV once daily. On day 11, the cultures had isolated Candida tropicalis. The speciation was done, and thus the patient was continued on injection anadrolfungin 100 milligrams once daily. From day 12 to day 14, again the blood cultures are repeated after 48 hours of initiation of anadrolfungin, which came to be sterile, and the fever started to settle with decreasing TLCs. And 2D echo did not show any vegetations, was done, which did not show any vegetations, and fundoscopy was done, which did not show any changes suggestive of Candida endophthalmitis. On day 15, the general condition of the patient has improved with no fever spikes, still requiring hemodialysis, and the patient was discharged at request to other hospitals in view of financial constraints. Follow-up of the patient has been followed up, and the AK has found to be resolved, and the dialysis has been stopped after 2 weeks with the patient in a clinically stable condition. So this is the investigation of the patient with the blood culture, which was drawn on the 10th day of the patient's admission, has shown Candida tropicalis, and this is the culture sensitivity report. So based on this, we have decided to continue anadrolfungin. So these are the serial investigations of the patient from the day of arrival till the time the patient was discharged from our hospital. You can see that the patient's hemoglobin status, which was initially anemic at presentation because of ongoing blood loss and DAC, which has later improved following the sequential the transfusions that has been taken place. And there was also the coagulopathy also started to resolve. You can see that the INR has been decreasing, and the total leukocyte count has started to decrease. But on day 10, the patient's total leukocyte count has also increased. So it was 28th was the day 10 of patient's ICU admission, where the TLCs have increased to 27,820, and this is the point at which the patient developed fever and where cultures were sent, and patient was started on anadrolfungin. So post that the patient responded well to the treatment, and the counts have started to decrease. But still, in view of persisting AKI, the patient was discharged in view of financial constraints, saying that she would require further dialysis at her hometown. So this is the investigations which are showing the LFT profile of the patient. You can see that the total bilirubin levels, which are initially elevated, and the SGOT and SGPT levels, which are initially the severe transaminitis was there, which has started to settle as the patient has clinically improved throughout the period of hospital course. Thank you, sir.
So, thank you, Dr. Bikas, for a nice presentation of the fungal infections in ICU. And I hope such cases as intensivist we deal many a times in ICU. And for fungal infections, I think your suspicions of fungal infections in patients, that matters a lot. It's not that you give everything, patient is still not improving, and then you start antifungals. So clinical suspicion of fungal infection, depending on the case, that is most vital, I feel. So now the session is open for questions and answer session by both the examiners and mentor, Dr. Tejas. I request all of them to ask questions to both the students, and later we can take up the questions in the chat box. Dr. Bikas, you can stop the screen sharing.
Yes, sir.
Okay, the first candidate was Abdul. And so my questions will be to Abdul first. Abdul, can you please tell me that your diagnosis was rhino-orbital mucormycosis? Subsequently, there was a complication and cerebral involvement was there. Okay, and that is the reason why you had to go up on your antifungal dosage. But my question is far more simpler than that. I want you to tell me what are the common sites of mucormycosis as a whole. You told me about rhino-orbital, but obviously rhino-orbital may not be the only one. There are other areas also which get involved with mucormycosis. So what are the other sites? And which are the more common ones? Which are the less common ones? Please tell me. Did you hear me? Abdul, did you hear me?
Dr. Abdul.
Dr. Abdul, are you
Abdul, you
there?
have to unmute. You
Sir,
have to
yes,
unmute,
sir.
Abdul.
Yes, sir. I can hear, sir.
Yeah, please answer.
Sir, most common site is sinuses and rhino-orbital sinus, followed by there are other sites like respiratory mucormycosis, abdominal mucormycosis, and even skin mucormycosis, skin infections.
Okay. I can tell you that, different areas of mucormycosis have different types of mucor species, but that is too high for you. That is not a question that I will ask you. My question was very simple, that unfortunately in the first hospital that the patient was in, that was the time when this patient should have got exenteration of the left eye. This was not done. And because this was not done, the brain got possibly involved. Okay, so you made the right decision when it came to your hospital. You made the right decision to do the exenteration of the left eye because FS was there done before also, but in mucormycosis, repeated FS is required sometimes. So that is not something new that you did. The question is that this patient in your contrast MRI did show the involvement of the brain, especially the saphenous vein, the saphenous cavernous sinus, and other areas. So obviously, brain involvement had taken place. The mucor had invaded into the brain, and that was through the blood vessels. And that is why the veins were the ones which were most commonly involved. Now, the question to you is that now that the brain has been involved, and we know that the drug of choice is liposomal amphotericin B, what should be the dose of liposomal amphotericin B if the brain is involved? Because the penetration of amphotericin B into the brain is not very high.
Sir, maximum dose is 5 milligram per kg. Patient was 60 kg weight, so we provided 300 milligram of liposomal amphotericin B.
Unfortunately, people have gone up to 10 milligram per kilo for brain involvement. Your 5 milligram per kilo was all right as far as it was confined to the rhino-orbital area. Once it goes into the brain, because of the poor penetration of liposomal amphotericin B, relatively poor penetration, the dose has to be increased, and people are advised to give both at 10 milligram per kilo of liposomal amphotericin B. If the brain involvement is definite, at least that the way you showed it in the contrast MRI, there is a definite brain involvement. Cavernous sinus has been involved. The infarcts are secondary. Infarcts are not due to the involvement of the mucor. It is due to the angioinvasive nature that causes blockade of blood flow in the artery and vein, more of them in the vein than in the artery, and you get venous infarcts in this condition. So the question is that, again, the next question that I would ask is that when the patient came to your hospital, you gave a combination therapy. You gave a combination therapy of amphotericin B with posaconazole. That would perhaps explain why you did not go to such high levels of amphotericin B. We'll talk about the side effects later. The question is, what is the evidence of combination chemotherapy in the treatment of mucormycosis?
Sir, advantage first is less chances of resistance. We can prevent the development of resistance. Second, penetration of the drug is more. Third thing is there is synergistic effect of both the drug and
My question is very
also.
simple. It's evidence. What is the evidence? I agree to all the things. I didn't ask you this question, the justification of it. The possibly justification was that you could not go to 10 milligram per kilo. So that's why you added posaconazole. That is something which I understand. But my question is that what is the evidence in favor of combination therapy in mucormycosis? All the reasons that you mentioned are perhaps right. But unfortunately, there is no evidence in favor of a combination therapy, though it is given. I don't deny that it is not given for the reasons that you mentioned. Most importantly, that it has got excellent posaconazole, being an azole, has an excellent penetration into the brain. It is effective against mucormycosis, and that is a posaconazole that was added because the brain got involved. But combination therapy, liposomal amphotericin B plus posaconazole, we don't have any evidence as of now which will tell us that combination is better than one drug being given alone.
We have a lack of evidence.
Yeah. Last question. This patient came to you from the other hospital with severe hypokalemia. What was the reason? Why did the patient have such severe hypokalemia? Any possible reason that you can
Sir,
think of?
the most common reason in this patient is maybe amphotericin B itself causes hypokalemia, and it lasted for longer time. Still, the amphotericin B was given initially conventional, then liposomal. So this may be the most common reason of hypokalemia. Other reasons.
You talk about deoxycholated amphotericin B was given in the previous hospital, which is this standard plain amphotericin B, as you are calling it. And that has predilection to produce hypokalemia almost in 100% of patients. My question is very simple. What is the mechanism of hypokalemia due to amphotericin B?
Sir, sir, exact mechanism I don't know, but it shifts the potassium.
Okay, we move on. I will call upon Pradeep to
Yeah.
ask any other questions on this topic. We will move to mucorma. We'll move to Candida later.
Yeah, so I think Muka, thanks, Prakash. I think you have covered most of the things. So my few questions, Abdul, is if you have a Mucor next, how different would you manage, considering this case as an example and the discussion we've had with Dr. Prakash? So how differently would you manage the next case? That is one question. I'll just put off the questions. The second question is, do you believe that isavuconazole or posaconazole, which are being touted as alternatives, is there evidence that one is superior over another, or your choices would be in the order of what you have done this time? And I completely concur with Prakash Shastri that there is no evidence of combination at this point of time. And is there evidence for chelation, and does iron chelation has any role in mucormycosis? And what are the studies favoring isavuconazole, which was a big trial? So these are the 4 questions. If you can remember, can answer one by one, and then we can move to the next case.
Sir, iron chelation, whenever there is a iron chelation deferioxam is used, there are chances of increased chances of fungal infection and mucormycosis in those patients, along with transplant patient.
No, see, Abdul, we are at a evidence-based sort of a practice, isn't it? There can be a lot of hypotheses, but is there a evidence for chelation has a role as a standard of care? Is the question. That's the last question I had asked.
With due respect, sir, I do know.
Okay. So please look into it. So there's not much
Yes,
evidence for that. Okay, then
yes, sir.
the other question. What is the trials that you know of the newer drugs that are evolving? Because there are a lot of newer antifungals that are coming, which are considered as equipotent. So with isobuconazole, which has been touted, so what is the trial and what is the outcome of that particular trial?
Sorry, sir,
Okay.
I'm not
Because
aware of the
because you
trials.
did use isobuconazole, right, in your patient.
Yes, sir.
So
No, he
it's
did. They did
important.
not. They did not. They use posaconazole. They
Posaconazole,
use
okay.
posaconazole.
Posaconazole, okay. So is posaconazole as an alternative, or do you think it's a de-escalatory drug, or it's a combination? What in the combination therapy trials? There are 3 trials that are done as a combination. What are the combinations they use? Did they use posaconazole or something else?
I'm sorry, sir. I haven't went through the trials. I went through
So,
textbooks only, sir.
okay. No, see, at your level, it's good. You have presented well, but at your level, we expect your post MD. It is good to know what is happening because these are the latest things that we would want you to at least know little bit. Okay.
Will do it, sir.
And okay, the other question I asked you, how differently would you manage? There was one thing concerning throughout this case. Routinely, there was a background antibiotics that were given, like ceftazidime, sulbactam, ceftriaxone, metronidazole. So, was there any rationale for using all these antibiotics alongst with a clear-cut diagnosis of mucormycosis for this patient?
Sir, we suspected as a patient stayed in civil hospital for almost 1.5 months, so there were chances of hospital-acquired infection, pseudomonas more likely. So, in focus of that only, sir, we first gave cefoperazone sulbactam. Patient didn't respond, so we escalated to meropenem till the culture reports arrived. Then we shifted to ceftazidime, avibactam, and aztreonam, which was the combination was synergistically sensitive to pseudomonas. That's why, sir, in view of that, we went through all the antibiotics.
Okay. So, Tejas, you want to ask anything?
Last question. Dr. Abdul, if
Yes, sir.
it would not be a mucormycosis, then what would be your second diagnosis? What other kind of fungal infection we could suspect in such kind of presentation?
Sir, it may be Aspergillus infection.
Okay. Yes, sir. We can move to next student, sir.
Okay, so Abdul, just a final comment. So just look at answers for all the questions because I know this is not a teaching session. So the combination they did not use in none of the trials I'm aware they used combination of amphotericin with posaconazole or isobuconazole and they're not recommended. They've all done trials in combination with echinocandins, the combination ones. And how differently, as Prakash rightly said, one would want to take a surgical consult at the upfront. You wouldn't wait because it is very, very invasive and you would have to, and always the therapy is surgical debridement along with the antifungal. It is not one exclusively. And do you think hyperbaric oxygen has had any role? That is something you can look at. There is some literature. So just try to look into this. The study that I was referring to is a vital study, which was done for isobuconazole. So just read about all those little different things. So Prakash, we can move to the next case, Prakash? Because we have 15 minutes more.
If I can interrupt, sir,
Okay.
some questions in the chat box. We shall answer it at the late, or can we take?
Better, no? I think we'll take all that in the end.
Chat box questions you can take at the end, sir.
Okay.
I think there are answers to some of the questions already. Someone has put vital trial, secure trial. But okay,
Yeah.
go through that. Yeah, you can.
Okay.
ERIC2 trial, someone written, no?
Yeah, we'll discuss at the end, the chat box.
We'll discuss. So second candidate is Vikas. Vikas, I have to congratulate you. Your presentation was quite good, quite comprehensive. I mean, obviously, there were certain things like, as Pradeep mentioned just now, maybe a bit improper use of antibiotics, which probably you did not have control upon. Maybe the patient was being treated by other units also. So that thing I will not. You managed the toxemia health part pretty well. My On that bit, I'll come to the fungal infection later. On that bit, my question to you is simple. You gave cryoprecipitate in this condition. What was your reason for giving cryoprecipitate in in your patient?
We have given cryoprecipitate in our patient, sir, because in the initial presentation, she was having initial investigations have suggested that the patient was in HELP syndrome, and the abdominal drain output was sanguinous of around 450 ml, indicating that the patient's coagulation status is impaired and the fibrinogen levels were around 40 on arrival. So these are the
That is the answer.
substantiation
That is the
reasons.
answer. That is the answer. I just wanted to hear the fibrinogen levels were less, and that is
Yes,
why
sir. Yes.
you decided to give cryoprecipitate in this patient. Anyway, you managed the patient pretty well. The patient was taken out of the ICU, and patient came to the ward. And unfortunately, she had developed a secondary infection, isn't
Yes,
it?
sir. Yes, sir.
Now, the question that I'm asking you is, which is the most common Candida species which is grown in Indian ICUs?
The most common Candida species that is grown in India is Candida tropicalis, sir.
In Indian ICUs? Can you
Uh,
refer a source for that? Any evidence?
It is the EPIC2 study, sir. The EPIC2 study is a global study which has found that the prevalence, the prevalence of the it is in the Western countries it is Candida albicans which is most common, but in the Indian scenario it is the non-albicans which is most common and it is Candida tropicalis. But as far as I remember, I guess that is it is secondary to the EPIC2 study, sir, that has revealed the.
Any Indian study? Any Indian study?
See, just to interrupt, because EPIC study is a global study, and you know how many samples were there in that?
Yes, sir. It was around it was 75. There were around 75 ICUs, sir.
99 candidemia,
Sorry,
that's all. 99
sorry, sir.
candidemias. They
99
studied
patients,
only
yes, sir.
99 candidemia. That is a very
Patients.
minuscule number. That's
Yes,
a
sir, yes,
Western
sir.
study, and we cannot relate it to our Indian. Na? Prakash Shastri is clearly asking you about the Indian.
Indian scenario. Yes, sir. In the Indian scenario, I'm not aware of
There
any.
are Gangaram studies there, AIMS studies
Yes,
there,
sir.
Saptarjung, all those data is there. I think it is important to understand our Indian epidemiology, isn't it?
Okay, sir. Okay, sir. Yes, sir.
Prakash,
So
Rahasi
Candida
can,
tropicalis is
yeah.
anyway. Candida tropicalis is what you did not know when you sent off the blood culture. You started this
Yes, sir.
patient on empirical antifungal.
Yes, sir. Yes, sir.
Yes, and as intensive care physicians are very fond of echinocandins, you
Yes,
started
sir.
this patient on anidula fungal. Among the three echinocandins that is available to you right now, we'll have
Yes, sir.
few more in the coming years, but at the
Yes,
moment
sir.
there are three. You chose to give anidula fungin to this patient. Any particular reason?
Yes, sir. The reason is, though we have Anadilla, Caspon, Micafungin, we chose because the patient was having a liver dysfunction. We didn't want to give the patient Caspofungin because the safety profile of Anadilla fungin is better, and even the studies have shown that the minimum inhibitory concentration was better with anidula fungin compared to caspofungin and micafungin. So these were the reasons, and patient was having a hepatic dysfunction. So these were the few reasons why we initially went with anidula fungin, and also the patient was critically ill with hemodynamic instability at presentation, and she was having an ongoing renal failure or AK. She was requiring persistent dialysis, hemodialysis. So these are the reasons why
You
we went
gave
with
anidula. You gave anidula fungin. You gave anidula
yes.
fungin on day 10.
Yes,
So
sir.
that has got nothing to do with what the patient presented with. The
Yes, sir.
patient was out of the ICU when you gave antidote fungal.
Okay.
But
Yes,
I
sir.
would agree with you. I would agree with you that antidote fungal is safe in the background of liver dysfunction. But in this
Yes, sir.
case, by the time you send the patient out of the ICU, her liver enzymes had become normal. The transaminases had become normal. Only the alkaline phosphatase and the gamma GT, they were still high. But that is a obstructive pattern that is seen in post-septic patients. So
Yes, sir.
in this particular patient, the only reason why you gave antidote fungal was because of pre-existing liver dysfunction. That is
Yes,
what you're
sir.
trying to say?
Yes, sir.
Okay.
And even we
Okay.
don't know the
Once you got the culture reports,
yes, sir. Yes, sir.
once you got the culture report, then you decided to continue with it.
Yes, sir.
My question to you is very simple. You sent off a blood culture,
Yes, sir.
and the blood culture initially mentions that we are growing BYC in the blood. The first report that you get from the microbiology lab is that we are growing something which is yeast.
Yes,
Agreed?
sir. Yes, sir.
So when you and you, now the question that I'm asking you is that if I'm growing yeast from a patient who has a central line in place, how
Yes, sir.
soon should you remove it?
Uh, if the patient is growing yeast, we have to immediately remove the central line, sir. I-
I beg your pardon?
you have to remove the central line because it could be a source of infection. But then since the differential time to positivity from the microbiology department was less than 2 hours, we have removed the central lines. We have removed since the cultures are showing it is a positive yeast, and yet the speciation was not done. We have removed the lines, sir. So that keeping in mind that it shouldn't be a focus of the infection, and we have replaced the guidelines
The
even say that we have
guidelines,
to one. Yes,
yes.
sir.
The guidelines mention that the
Yes, sir.
line should come out as soon as possible,
As soon as
definitely by
possible.
24 hours, and if not by
Yes, sir.
24 hours, definitely by 48 hours.
Yes, sir.
Okay, so that is the thing. So
Yes, sir.
I agree that there are various yeasts available reported in the microbiology lab, but we are confining our discussion to Candida only in this particular discussion.
Yes, sir.
My question
Yes, sir.
is, again, the next question is that normally, as your culture report also mentioned, Candida tropicalis is sensitive to fluconazole.
Yes, sir.
And we have got huge experience of using fluconazole, relatively
Yes, sir.
safe drug to give.
Yes,
Why
sir.
did you de-escalate to fluconazole afterwards once you got the species and the culture sensitivity report?
uh, the rationale behind it was that the patient actually went through a critically ill phase, sir. And she was still ongoing. There was ongoing AKI with hemodialysis. So putting the patient on fluconazole, the pharmacokinetics and pharmacodynamics of fluconazole in a patient with renal failure are unpredictable. So that is the reason, and even the culture sensitivity reports were showing a MIC value of more than or equal to 64. So these are the few reasons, sir. The why we haven't, and we didn't want to. Since she was already critically ill, and on presentation also she was having high Apache scores. So these are the reasons, sir,
None of
why
your
we
answer
didn't
is
want to.
right, I'm afraid. Because, can you stop for a minute?
Yes, sir.
None of your answers are right, I'm afraid. The point that has been made very clear in the guidelines also, it is the sidality of the molecule. Echinocandins are bacteria or fungicidal.
Yes, sir.
Fluconazole is fungistatic. And that is why in a
Yes, sir.
sick patient, I would rather use a sidal drug than a static drug.
Rather than
You were
okay, sir.
trying to give all the explanations. It was basically throwing darts in the dark. You were trying. I must say, I have to give you the credit for that. But unfortunately, the answer is very simple. It is a sidal drug. The
Okay,
other,
sir.
a better answer would have been that the resistance to fluconazole in Candida tropicalis in various big centers of India is hovering around 10%. And
Okay, sir.
10% is an arbitrary value beyond which we do not give that drug, especially in a critical scenario like you find in the ICU. Now, I don't know what is the fluconazole resistance in tropicalis in your hospital, but yes, as I said, 10% is the usual value beyond which I would not give that drug. And that depends upon my hospital microbiology reports. They can tell you what is the incidence of resistance to Candida tropicalis. Tomorrow you can find out. And it is hovering around 10% in most of the big hospitals, big ICUs. And that could be another reason to choose an echinocandin over fluconazole and not to de-escalate even when
sensitivity reports
you are getting the report, which is showing sensitivity. It doesn't matter. MIC 64 doesn't matter. It is sensitive. The break points are less than 64. So that was completely right. So your answer should have been this, that there is a growing, or you can say a creep of resistance in Candida tropicalis to fluconazole, and especially in a sick and precious patient, I would perhaps not use it. Okay, Pradeep.
Okay, sir.
Yeah. Yeah, so very pertinent questions, Prakash. So because again, pointing to a lot of antibiotic usage, which all of us agree is something which possibly we should look into. So in the context of that, can you elucidate the key risk factors this patient has had, keeping the context of the statements made by me and Prakash, the risk factors for candidemia in the order of the odds ratio based on the evidence, which has the maximum odds of putting them at a risk for candidemia. In your own presentation, they were all there. That is one question. So I'll put off all the questions so that becomes easy. We are running short of time. The second one is, what are the newer diagnostic tools that you would adopt in diagnosing candidemia? Because cultures obviously take some time, and we may have had some lag time until the blood culture showed yeast, before which there may be a delay in the initiation of suitable antifungal. That's the second question. And third question is, please tell me the difference between definitive therapy, empirical therapy, and preemptive, because there are a lot of studies looking into whether there's any difference where you foresee a risk and you start empirical or preemptive. Definitive, of course, is easy, what possibly you may have done. But that why we are talking on this is whether we would preempt and start little early on, because the delay in antifungal also has shown sequential increase in the mortality risk. So these are the three questions. And fourth is just throw some light on Candida auris and the choice of, because that is the problem we tend to face of late, and their occurrence rate or the epidemiological prevalence seems to be increasing. So these are the four questions. You can answer one by one.
Yes, sir. So the first question, what are the risk factors in the patient, sir, in the order of severity of odds ratio? So in our patient, the first risk factor is the presence of a central venous catheter, as well as the presence of an hemodialysis catheter. So invasive lines is one of the first risk factor in the order of preference. The patient is having this is the first risk factor. Second, the patient was put on broad spectrum antibiotics, and after that, the patient had a prolonged ICU stay. And later she had underwent a surgery she has underwent a hysterectomy. So this is other reason. And once the patient is in ICU, she is also put on the antacid prophylaxis that has been done. It is also found to be another risk factor for invasive candidiasis. So these are the few of the risk factors in our patient who was presented here, sir. So
good. So which means our whole effort should be to limit at least some of the risk factors, isn't it? I agree, most of it is correct. Just for the audience, I think the landmark studies from the Puznaik et al. That is the landmark which has done largest series to look into the odds ratio. CVC had an odds ratio of 9.5. Second was the stress ulcer prophylaxis, which had 6.4. That's why we try to de-emphasize on routine stress ulcer. And the fact that in ICU is odds ratio of 6.4, nasogastric has 3.7, antibiotic ratio also is 2, odds ratio of 2. So those are the order. So we have to obviously curtail indiscriminate usage. That needs to be emphasized. And your patient had a lot of antibiotic usage. Okay. The next question, newer diagnostic tools that are in place, and what are the studies telling us?
In patients in whom we are suspecting a invasive fungal infection, serological test in the form of 1,3 beta D glucan or in the form of a mannan antigen and anti-mannan IgG antibody can be sent for early diagnosis of patient having invasive fungal infection. Apart from that, even the Candida 2 test, where the PCR is correlated with the MRI.
You mentioned,
So
just to interrupt, you mentioned beta D glucan. Would it tell
yes,
you
sir,
it
yes,
is
sir.
a yeast candida or it will come positive? What is its value? Beta D
Yes,
glucan.
yes, sir. 1,3 beta D glucan. It is actually it is a pan-sensitive fungal marker. Apart from you don't see it in it is in positive in Cryptococcus as well as in mucormycosis. Apart from these
Yeah,
two
so it
species,
doesn't really help you to
help in this. Yes, sir.
stratify, isn't it? Or
Yes, sir.
specifically
Yes, sir.
point out to any particular fungi. It gives you a very broad thing. Even pneumocystis, it comes positive, beta D
Yes,
glucan.
sir. Yes, sir.
So we have to be cautious in picking that as a tool because it is maybe a little expensive, not very much. It's a good negative predictive. So
Yes, sir.
I don't think it will give you a direction to it. What are the other newer tests
Other newer tests,
which we are
we have the
using it routinely to identify fungi early on, along with cultures as a concurrent additional synergistic value?
the PCR, sir. The PNA fish PCR.
Okay.
The
Yeah. PCR, I think many studies have shown good value of PCR, and MALDI-TOF is there, and T2
yes,
Candida
sir.
panel. So that is
Yes,
still
sir.
yet to be widely available.
Yes,
So
sir.
we need to be aware of newer tests because we are increasingly using this to even identify early on and start suitable antibiotic. Okay.
Yes, sir.
Yeah. The third question is about empirical and preemptive. Are you aware of what the definitions
Yes,
are?
sir. Yes, sir. Prophylactic. So there are four therapies, sir. Prophylactic. Then we have the preemptive, then the empirical, and the definitive therapy, sir. So prophylactic is when the patient doesn't have any fungal infection, but you are having a suspicion that the patient can develop a fungal infection and start the patient on antifungals. That is prophylactic therapy. Then comes the preemptive therapy. Preemptive is where the patient is having a positive serological marker in the form of positive serological marker with a high index of suspicion. When you start the therapy, that is called as preemptive therapy. Empirical is when the patient is having signs and symptoms
Okay,
suggestive
good.
of.
So tell me now,
Yes, sir.
that there are multiple trials, just for the audience, there are multiple trials comparing whether we should be empirical or preemptive in our approach to start antifungal, and which we call it as antifungal stewardship. That's a big thing evolving now. So what did studies tell us? That should we be little overzealous and start empirical, or we should be preemptive, or we should wait for definitive? What are the studies telling us?
Uh, uh, Studies are telling us that if in a high risk patient, starting the patient on prophylactically will reduce the will reduce the hospital mortality and also reduce the morbidity and mortality. So and even coming to the preemptive therapy or the empirical therapy, once the if the cultures come out to be positive, and if you try to delay the therapy even for a period of 12 hours, the mortality is found to be increased by around 200%. So once the with a high suspicion of mortality, because cultures are not always positive, sir. Even in patients with invasive candidiasis, the cultures are always not tend to be positive. Only 30 to 50% of the cases the cultures are positive. So not always do not rely on the cultures. And if you are having a high index of suspicion, the patient having adequate risk factors, then it is better to start the patient on antifungal. So in order to prevent the morbidity and mortalities.
Are you saying preemptive is better or empirical is better?
Preemptive is better, sir. Preemptive and definitive therapy are better compared to empirical, sir.
You would de-emphasize on empirical.
Yes, sir.
Okay. Okay, I think just for the
So,
audience, I
can I
think,
interject, Pradeep, for a minute?
please, Prakash,
For
please,
a minute.
Prakash.
Because just one thing I wanted to tell you, that you have to be very careful as to what is the question that is asked to you. Pradeep was very clear that he asked you about the role of empirical antifungal therapy in ICU patients. There's an empirical study which has been done, which actually looks into this precise question. Now, instead of answering that question directly, you went around all around the bush, and of course, it showed off your knowledge about antifungal therapy, all right, but it didn't cut any ice with me. I'm not going to give you any extra marks for that. So that is, be very careful. You should do the technique of the examination as well. You have to answer the question that is asked. If you volunteer information and if you think that the examiner would be impressed by your depth of knowledge, then I'm afraid you are missing the trick. You are barking up the wrong tree. So that is where again you have to learn the art of when you or technique of answering questions. The examiner is always very specific in asking questions. So please and please stick to what is asked for. Don't volunteer extra information that doesn't go in your favor at all. The examiners in front of you are very senior people. They
I'm
are
sorry, sir.
they know they can sense that you are trying to deviate the examiner into a different discussion, which doesn't go well with the examiner at all, whoever is the
Yeah.
examiner. So that is why be very specific. In this particular question, the question asked to you was, what is the role of empirical antifungal therapy in ICU patients? The answer was very simple. There's absolutely no role. The empirical study did show that there was a decrease in
Yeah.
the incidence of fungal infection, all right, but there was no difference in outcome or mortality.
Yeah.
So the role of
Absolutely.
empirical therapy is absolutely zero, and that
Yeah.
is what should have been your answer.
Yeah, but I don't know
I'm
why you are
sorry.
mentioning prophylaxis. I didn't even ask about prophylaxis. So just for all the
No,
This is
audience,
what
say
he
like Prakash,
volunteered. He
I think the
volunteered
best
such
sorry.
is,
thing.
yeah, best thing is Prakash ji and me have been examiners few times, so we exactly know. And please, for all the examiners, even I tell my trainees, we are very careful in listening to you. Although you may think we are doing this and that, we exactly know what we have asked. When you are answering something differently, we also know that you are answering differently. And invariably, we can identify within 2 minutes whether you are telling the right thing or just, beating around the bush. So that is a very valid point, and speak slowly, because I know you have a lot of knowledge, you have read, but when you answer, we expect you to, as Prakash said, be specific to the question that we have asked and be slow in answering. When you rattle out very fast, we would be hearing out, but we know there's not a lot of things what you may have said is not relevant. So that is important for all the listeners, not because see, this is a very easy situation where you have read everything. Honestly, me and Prakash haven't read anything because we just came. Came back from work and I'm sitting here. So we expect you to answer some of these because having read through your present, because you know your presentation. Me and Prakash were blinded to what you both were presenting. Honestly, I didn't know you were presenting aspergillus. I didn't know you were presenting tropicalis. So now tell me
Yes.
the last question. Oris, Candida auris, what is the burden at this point of time in the order as we see it? And what is the peculiarity of auris compared to the other conventional tropicalis and albicans, glabrata, cruzi? Auris has some distinctive sort of characteristics at this point of time in India more so. So what is it?
Pradeep, can I
Yes.
interject?
Yeah.
I need to go. There's a ritual at home. So
Yeah.
can
Yeah.
you carry on
Yeah,
from
we are
now
done,
onwards? You are
Prakash.
done.
Yeah, you can leave,
Okay.
but we are
Mm.
almost done. 8 o'clock is done, so we'll close
Okay.
it after this questions. Thank you
Thank
so
you.
much, Prakash. Excellent
Welcome.
inputs from you. Greatly
Thank you.
appreciate.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Yeah,
Sir, your last
can
questions, Pradeep
last
sir.
question, and then we'll close it
Yes,
with
sir.
Anandji and Tejas
Yes, sir.
comments.
Few questions in the chat
So,
box are also there, sir. We can take
Yeah,
up at the last. Yeah.
yeah.
yes, sir. Candida auris is an emerging infection, sir, and it has found to be having the species has found to have a azole resistance, that is the reason, and it is also difficult to treat with azoles and amphotericin B. These are a few reasons, sir, why it's
No,
found to be an emerging infection.
I asked you a specific questions. There is a
Yes,
unique
sir.
characteristic of this because resistance to azoles, what you said, happens even with glabrata, even it happens with cruzi. But Oris has some sort of a uh, characteristic which annoys us. It is an annoying characteristic for all of us now in ICUs. Yeah, someone has mentioned. So this has a very rapid spread. It is cited as the fourth commonest nosocomial infections in ICU, and it spreads it's like MRSA. It can spread. It can cause outbreaks in ICU. This is a problem. When we have Candida auris, we need to have reverse barrier and contain that infection. Otherwise, it's like an Acinetobacter outbreak, or it's like a Klebsiella outbreak, MRSA outbreak. It's like that. It rapidly spreads. This knowledge we expect every intensivist to know, because you need to take necessary measures to curtail the spread, because it has resistance to everything. Even echinocandins, it has 10% resistance. So this is a problem bug for us now. So if you do not know in exam and tell me this, then we would be worried as examiners that this, because this is a huge infection control issue for us, Candida auris, and that is why it is so terribly important that we contain this and we take necessary measures to prevent its outbreak. Okay, so thanks, guys. I think you all did well, but we would love you to present at a little higher level so that all this evidence-based, because see, all intensivists at my level, if I am examiner, we will ask you for evidence because whatever you said, this can come out even from MBBS or post-MD person, but at intensivist level, we expect what are the studies happening, what are the key elements that we expect you to know, because that is what makes us different to other specialties, isn't it? So we want you to be upbeat about knowing the latest sort of a evidence that is evolving in any area that we talk about. Okay, so thanks everyone, and over to Anand and Tejas and Bhavani.
Yeah, Dr. Bhavani.
Yeah.
Yeah, I hope you can take up the questions in the chat box and finally give a closing remark.
Yeah, can we take a couple of questions, sir, in the chat box? If you are okay, then we will close the session. Yeah. So some of the questions, most of the questions have been answered, and most of the questions were part of the discussion. So one thing, one of the question was the optimal duration of amphotericin or posaconazole in rhinocerebral mucormycosis is one thing which was asked in the chat box.
Who wants to answer? Candidates?
Sir,
Anyone?
Sir, a book mentions that it can continued up to even 12
Miss
weeks.
Abdul, in ICU, I mean, at least for me, I wouldn't like to hear book. You're not the textbook readers. At intensivist level, we want you to be updated. Textbook lags behind the evidence by at least 5 years, minimum, or even up to 10 years. So if you say textbook means you're not updated for at least 5 years. So just a correctional factor for all because I tell all my trainees, you have to read the journals, you have to read the recent evolving evidence, or even stick up to date. It will give you what is the current evidence rather than saying textbook. So just a correction factor for you. Don't mention like that in exam because I'll get very annoyed if you say I've read some textbook because textbooks are old.
Sorry,
I don't encourage anyone honestly to read. Textbook is a reference for understanding the basics, not to answer the questions that we ask. So tell me, what is the duration as per the evidence?
Sir, up to 12 weeks we can continue tablet posaconazole.
I would be unhappy with such answers. Is there any timeline put in? 12 weeks, 6 weeks? What if I said by 12, I'll give 11 weeks? What
Sir,
should your answer
till
be?
clinical and radiological evidences are there of
That's a better way. That's a better way of answering. See, in these mucormycosis, the duration is until the resolution of symptoms, microbiological clearance, and radiological clearance, and resolution of symptoms. You will be guided by that. But of course, and the duration is calibrated to that. Of course, it will be for many weeks. And no one says 6 weeks, 8 weeks, because sometimes they can give even for 12 weeks or 8 weeks or 10 weeks until the whole resolution happens. So radiological, microbiological, and clinical resolution would be the answer. And with the timelines of at least more than 6 weeks, at least it will tell me that you have a horizon towards the clinical resolution and seeing a logical end. There's no definitive endpoint in these infections, especially mold infection. There's no definitive timelines. Be it aspergillus, be it this, you give it for a protracted period of time until complete resolution happens. Any comments from Anand or Tejas or anyone?
Absolutely, sir. What you said, I think it is for the audience that these are the tips of the clinical pearls that we should be aware of while answering the questions in the examinations, and that is why this session is. I agree fully to you, sir.
And in that answer, the fourth one is reversal of underlying immunosuppression also. That also should be
correct.
Until clinical resolution, radiological, microbiological, and treatment of underlying, if it is cancer or immunosuppressive or steroids.
Primary condition.
Primary problem.
Any more questions, Dr. Bhavani?
I think in chat box, most of them have answered the questions that we were throwing as I see it. Most of them seem to be answers, Bhavani.
One thing, isoconazole, I think, is fast emerging antifungal. Any evidence of isoconazole superiority?
I think no, there's no superiority. In fact, the guidelines suggest that combination of amphotericin B with these to be de-emphasized because it's a de-escalatory drug at this point of time. It's not a primary drug unless for whatever reason you are unable to use. So because that's what vital studies and all were non-inferior studies. They did not show any superiority or thing. So you can read through these studies.
Any role of
See, in the vital study, the mortality day 42, it was a very small study. They did it in, I think, 37 patients and 54 patients, amphotericin. So here they combined amphotericin B, just for the audience, amphotericin B with isobuconazole compared with amphotericin B. And they found non-inferior day 42 mortality in combination of 33% and 39% in amphotericin B. And weighted all-cause mortality also, there was no difference, 33 in combination versus 41. So it's a non-inferiority study which was done in combination actually. So there was no benefit.
amphotericin B around the eye mucormycosis, orbital mucus.
And regarding the fungal biomarkers, I think few things we have already discussed: the galactomannan and beta-D-glucan. Anything to add, sir?
Yeah, see, galactomannan is when you are suspecting aspergillosis, and beta-D-glucan is it's a good negative predictive value. If you are immunocompromised, if your beta-D-glucan comes negative, then at least there is no fungus to think about. If it comes positive, obviously you have to work up doing cultures, doing tissue culture, and doing your PCR or Candida panel or Malditoff. So you have to adopt these to identify the fungi. It will only tell you because why? This is to prevent empirical usage, because if beta-D-glucan comes next, at least you don't have to target all these different nasty fungi that may be there. And if you have a lung lesion, generally the preference is to do galactomannan because aspergillus predominantly tends to affect the lungs. So your pickup rates would be little better to identify aspergillus by doing galactomannan. But beta-D-glucan, the advantage is it can identify pneumocystis, which is a problem, and this is little more commoner in immunocompromised. That's why we tend to do beta-D-glucan as a screening, and if it comes positive, we have to look for, along with the conventional fungi, we have to look for pneumocystis cerevisiae as well. And we have picked up pneumocystis where our beta-D-glucan has come positive. It's a good screening tool.
Right, sir. And Bhavani, any more questions, or I think almost all questions have been covered up?
I think in view of shortage of time, I think we'll close this session. Actually, we had a very productive discussion and brainstorming about fungal infections. More importantly, the students got a perspective about how to answer in the exams, and also to be to the point, not around not discussing irrelevant things, rather than discussing what is relevant to the question. First of all,
moreover, I think Dr. Bhavani, as Dr. Prakash Sastry sir and Dr. Pradeep said, you have to be to the point. You cannot go around. You cannot beat around the bush, and you have to be specific about what is being asked and accordingly. And second thing, Sastry sir said that while you present, you have to answer slowly, clearly, and transparent to the point. So these are the tips I think for the students they have to remember, and these are really helpful in the examination.
So sorry, sir. Was tensed. That's why I was presenting.
No, it's okay.
Sorry.
It's okay.
Sorry.
It's
Actually,
okay,
because this was a better place because you knew the case and you could prepare. Now, just imagine exam. You'll just get a case where you don't know what case it is. So keep presenting more and more. So it's just to understand how we look at it from our end.
I'm sorry.
Actually, because that's what the whole point of this program is, getting you exposed to such discussions be helpful for you in your exam. So that is the whole point of this ICU clinics. So I mean, this might be the take-home message from here. So with this, I think we'll come to the end of this session. First of all, I would thank participants who have joined in large numbers. Almost 190 participants have joined, and I would thank Dr. Abdul Syed and Dr. Vikas Reddy, who have presented amazing cases from actual clinical scenarios. And I also thank Dr. Tejas, who have mentored these two students in presenting these cases. And last but not the least, we had two amazing examiners, senior examiners, who has a great experience in fungal studies, Dr. Prakash Shastri and Dr. Pradeep Rangappa. And they gave insights into the antifungal, insights about how to present in an examination. Thank you, sir. Thank you both.
Thank you.
Prakash Shastri, Dr. Pradeep, sir.
Thank you. And Ranveer is there. Maybe with the point,
before
Ranveer,
we close, yes, I would like to give that credit to Ranveer sir and ISCCM, Indian Society of Critical Care Medicine, for giving this platform. And I think it is very well. 10 years back, this type of sessions, webinars, opportunity to the students, exam going students was not there, which is being there, and it is being provided by the ISCCM. I think that is a great opportunity for the students, exam going students. So thanks to Ranveer sir for having this idea, who is the brainchild of Ranveer sir, I think, and ISSM, Indian Society of Critical Care Medicine, for giving this platform to the students and real exam scenario. And thanks to Pradeep sir, as always.
Yes, along with Vikram, we started first and we think about that because we feel most of the students are neglect. This is the most neglected part. I believe practice make men perfect. So once he presented, as Pradeep mentioned, go on presenting. And on the final day, you have no difficulty. So this is motive of starting ISCCM ICU clinic. First, I discussed with Dr. Vikram. Vikram, any comment?
Vikram silent हो गया, बहुत silent है.
Dr. Vikram,
silently watch कर रहे.
Amazing presentation. I think more than 200 students attended or clinicians attended.
Yeah,
200. That is great. That is great achievement because here no attendance is compulsory. In step,
maybe one suggestion, Ranveer boss, is to take feedback from students about these clinics every time, so that we can get better and better. Because at the end of the day, it's a collaborative sort of a exercise where we also have to get better, no?
Yes,
because we need to understand what they expect from us.
Yes. So definitely, Pradeep, definitely. Yeah. Thank you, Pradeep. Amazing, Bhavani.
Thank you.
And Anand, all Tejas. Excellent, amazing teamwork.
Thank
you.
Bye.
Thank you, sir.
Thank you all. Have a good festival. Today is festival for all of us.
Enjoy Rakshabandhan. We will meet Pradeep in tomorrow evening with dinner.
Yes. We are going to meet Ranveer boss. Thank you. Thank you all.
Thank you.
Good luck for all the students.
Thank you, sir.
God bless you all.
Good night.
God bless you all.
Thank you, sir.
Thank you and good night all.